Hi, I'm Eric Nelson, one of the consultants with the Strategy House, and welcome to this short educational primer on medical staff development planning. It's also commonly known as community-based physician need assessments or physician manpower plans. This is a short video condensed from a longer webcast. Our goal in this video is to quickly give an overview of the medical staff development planning process, what we're going to touch on, what it is, why it's necessary, what are the inputs and the outputs, and what are the deliverables that you're going to receive from us. A medical staff development plan begins with an objective community-based analysis of physician requirements for a given service area, typically over a 5-year planning horizon. At a minimum, it helps a not-for-profit hospital comply with OIG and IRS recruiting guidelines, although it can also function as an important strategic planning tool for hospitals by targeting recruitment, addressing shortages, anticipating medical staff retirements, and identifying access problems in the community. So why complete a medical staff development plan? Well, without proper documentation of community need, a not-for-profit hospital can lose its 501c3 tax status. In order to offer many typical recruiting incentives, including stark, safe recruiting methods, a hospital must document the community need for physicians as opposed to strategic need. It helps to identify medical staff likely soon to retire. Many hospitals face a daunting task to simply replace these retiring doctors. The plan also serves as an objective reference document to reduce conflict in medical staff recruiting debates, although it can also aid in physician alignment by assessing potential acquisition and employment partners. It's also helpful when assessing the impact of the defection of a major group to a competitor. So what are the inputs? Using your hospital's patient origin, we define a service area for the facility. We then use internal medical staff listings, proprietary databases, and the websites of other providers to determine the existing physician inventory. This list is then adjusted for office locations, specialty listings, teaching and residence, and potential retirements. Using published and proprietary resources, a physician to population-based ratio model is set up to determine the net need in the service area. This model is tailored to your market with ratio benchmarks and population adjustments for extenuating circumstances like colleges, prisons, snowbird retirement effect in retirement areas, or peak demand in vacation resorts. We then interview key medical staff members to understand issues facing the staff. An anonymous web-based physician survey is also administered to determine any recruiting or operational issues facing the medical staff. Other factors for the area are then examined, including disease incidents, federally designated health professional shortage areas, aging of the population, the percentage of the population that's uninsured, the use of physician extenders, as well as others. So what are the key outputs? The compilation of an accurate physician inventory for the service area is crucial to the quantitative need model. That said, it's very difficult to complete the list strictly based on database inputs. After the list is compiled, it is important for hospital members to review it for accuracy. The quantitative model is then run for the projected service area population, accounting for existing physicians and expected retirements. The results of the model are presented on a service level basis and for each component area, typically counties or zip codes. All of these inputs are weighted and presented in a one-page evaluation matrix which prioritizes physician need by specialty. This analysis results in a report detailing both the process and the results. From these results, implementation grids are created which specify the FTE recruiting requirements at the hospital by specialty, by year, for the 5-year planning horizon, along with the justification for the allocations. This step is usually completed first by the Strategy House and then verified and adjusted during face-to-face meetings with hospital management. The resulting implementation grids are a great way to easily see recruitment targets at the hospital. This is the summary sheet for the hospital showing recruitment targets by year, by specialty. This sheet shows an implementation grid for primary care. One of these sheets is included for each specialty. So how can we help? We're process-driven and we have the skills and regulatory expertise to make this all easy. More importantly, we have the credentials and expertise to avoid the medical staff debates that can ensue when medical staff planning is not done properly. For more information, including a discussion of your individual needs, please feel free to contact us.